But for those who are not the members of Academy, will have to give a formal intro for him. Dr. Rajiv Jain is a senior consultant with the Indian Railways, New Delhi, and he is a MBBS from Maulana Azad Medical College, New Delhi, DCH, MD, DNB in Hospital Administration and Health Administration. And he's got certificate and diploma courses in the Chinese language. He has been the Director, Health and Family Welfare in the Ministry of Railways from 2006 to 2011. He is the Vice President of the Indian Public Health Association, Railway Service Branch. And of late, sir, you have also been awarded a fellowship on occupational health. I recently came to know about his extreme interest in occupational health, that is his key area. And going over to the topic, what we are going to take up today, the topic has come up with a background because with the increasing expectancy of life in the country and world over also, now the demand for integrated healthcare for those who have long-term care needs in advanced age is growing. So Dr. Rajiv Jain is going to develop on this topic, and sir, the modality of today's webinar is that you are going to present for about 40-45 minutes, followed by the QA question answers. If any questions are there during the talk, they will put in the chat box by those who are attending, and at appropriate time we will put that question to the speaker, and in the end there will be a comment section where you can prepare your comments for interaction and discussion. The whole duration of the program is around 1 hour, so I don't waste much time. Over to you, Dr. Rajiv Jain. Just a minute before Dr. Rajiv Jain comes.
Thank you.
Just a minute, sir. Just 1 minute. Our president, sir, will you speak in the beginning or in the end? Okay, so sir, I will like to ask our president, Dr. Yashpal Sharma, to say a few words about the speaker and his thought process on the today's topic.
Yeah, thank you, Dr. Ashish. Can only say is that I'm really very happy today that Dr. Rajiv Kumar Jain is with us. Senior colleague, very experienced person. He has a lot of accomplishments in the life. We are proud of you, sir. And we were eagerly waiting for you, to come to one of these sessions. So I'm thankful to you first of all. Then, as far as today's topic is concerned, topic is very relevant. You rightly said that the life expectancy has increased, and with the increase in the life expectancy, we have many old people, the number growing day by day. So we have to take care of them, and what will be the role of the state government, what will be the role of the central government, and how we can give them affordable care and accessible care. That's a big challenge. So I think Dr. Rajiv Kumar Jain will be the best person to talk about this, and we are eagerly waiting to listen to him. I will not take much of your time. In the end, I will have another announcement to make for the next webinar. So thank you very much, Dr. Ashish, and good luck to you, sir. We are waiting for you to start this session.
Over to you, sir, or Dr. Rajiv Jain.
Thank you. Thank you, Dr. Yashpal, as well as Dr. Ashish, for the kind words that you spoken. Academy of Hospital Administration is something which is so much ingrained in our growth process, and it's like speaking with our people of the family. And I'm grateful for the Academy to give me an opportunity to talk about an issue which remains neglected in the area of health and hospital administration. Because in our country, maybe we need to think aloud as to what would be the model for provision of integrated continuum of long-term care in India. Other Western countries, yes, we have some models available, but do we have any model of any kind for long-term care of individuals? And are we prepared to manage the extreme growth of people who are going to live long longer than we expect them. So in the next 20 years or so, India will be dominated by a substantial number of people who require long-term care, as opposed to a very short-term care which is required due to acute illnesses. So let's understand what is the requirement to have a roadmap for provision of integrated long-term care in India. Next slide, please. Despite the increasing number of older people globally, late life experiences of health and well-being vary dramatically and are not distributed equally either between or within populations, resulting in huge disparities in how aging is experienced globally. For many, the increase in life expectancy seen worldwide has not meant more years of life with good health. Instead, in some locations, a large proportion of those additional years are spent in poor health. Approximately two-thirds of people who achieve old age will probably need care and support from others to perform activity of daily living. Two-thirds is a proportion of people, such as feeding, moving around, and bathing, at least at some point in their longevity pathway. Fluctuations of functional ability are multi-directional, meaning that there is not a single path for everyone or the same trajectory of functional ability within one person's aging trajectory. So it has to be unique, it has to be tailored to an individual requirement, and then we should progress. So what could be the requirements of this roadmap? Next slide, please. So to understand the comprehensive nature of this long-term care, I've given you the domains of functional ability that we require. First of all, an essential is meeting basic needs. Then, learn, grow, and make decisions together and be mobile and build and maintain relationships and contribute to the society. So this four petals, along with the continuum of the base, the meeting basic needs, will form the functional ability basis. Next slide, please. What could be the framework for healthy aging? Now, if you see at the base, you are seeing change how we think, feel, and act towards age and aging. Over this base, we need to build environments, that is, remove barriers to compensate for loss of capacity and also promote capacity enhancing behaviors. If we have these two layers, then we go for long-term care, which requires ensuring dignified late life and also support capacity enhancing behaviors. Over these three layers is the fourth layer of the health system, where managing conditions, reverse or slow declines, and prevent and detect chronic conditions are also based. If we achieve these would form the helipad or the airstrip over which the flight can take off. Then we could have, if you look at the high and stable capacity, declining capacity, and significant loss of capacity as the process goes on. The black lines signify functional ability, the gray line signifies intrinsic capacity, and the green one is the supportive environment. Only then we could have functional ability optimized due to supportive environment. These together, this model is something which needs to be understood if we have to provide a continuum of long-term care in India. Next slide, please. Now, this is the service composition of implementing integrated care for healthy aging. And you'll see different colors and different ways in which this process goes on. At the bottom is the biological aging from left to right. All through the process, you need care, coordination, and social support. All through the process, you need management of underlying health conditions. All through the process, you need acute care. And all through the process, you need rehabilitation. But as the aging goes on, you need gradually increasing assistive care and caregiver support. You also need increasingly higher amount of palliative and end-of-life care. Over that, you need to understand that prevention of decline in intrinsic capacity is also required throughout the process. Also, promotion of intrinsic capacity have to go hand in hand. And in the population, we have to see that functional ability and intrinsic capacity is ensured, ensuring long-term care is provided. The gray area on the right is the long-term care that we are talking about today. Next slide, please. This is the integrated continuum of long-term care framework. And this is most important for all of us to understand who are in the business of health and hospital administration. The base is the leadership. And in the center, you have the 6 elements. What are those 6 elements? Governance. You have sustainable financing. Then third is information, monitoring, and evaluation. The fourth component is workforce. The fifth one is service delivery. And the sixth one is innovation and research. These are the 6 elements which are the core of the integrated continuum of long-term care. Over that, you have to ensure, as Dr. Yashpal was mentioning, equitable, affordable, and accessible. Also, upholding human rights and dignity, and most of all, person-centeredness. That means it is individually tailored. So these 3 components form the base over which the principles of government stewardship, whether state government or government of India, and if we ensure all these layers to be in place, then we have to ensure the outcome, which is optimizing functional ability. So this is the core diagram through which we will dissect and discuss further in the subsequent slides, especially the 6 components which are there in the circle in the center. Next slide, please. Now, this is the dedicated focal multi-sectoral coordinating body at the national and subnational level. At the national level, you also see the focal multi-sectoral coordinating body, and in the subnational level, that is the states, you also have similar subnational, but you see the arrows between the center and the states, between the states are more important. If only center and states are linked, the function will not be comprehensive, it will not be continuous, as you would have seen during the pandemic. People travel from one state to the other. You need to ensure coordination happens between the states as well, in addition to coordination between the center and the states. Next slide, please. Now, when we discuss the elements, we need to understand what are the definitions of long-term care workforce. There are 2 kinds of long-term care workforce. One is the carers or caregivers. For example, informal caregivers or informal carers. These are the individuals who provide care for a member or members of their family, friends, or community. They may provide regular, occasional, or routine care, or be involved in organizing care delivered by others. Carers and caregivers are distinct from providers with a formal service delivery system and most often provide unpaid care. On the other hand, we have care workers. They are professional, they are formal caregivers and carers, and they are social workers and nurses. These care providers are associated with formal service delivery of different forms of long-term care. These people are organized and they work for money as well. Next slide, please. Now, first of all, as you know, the 6 elements, the first was governance. And we shall now understand what are the key aspects that should be considered for long-term care governance. And similarly, we shall discuss about the 5 other elements, the key aspects that are required. First and foremost is include long-term care within the portfolio of national and regional or municipal governments with the designation of a dedicated focal coordinating body aiming at reaching leadership and engaging community representatives and other relevant stakeholders. First and foremost. Second is formulate legislation for long-term care that includes a mandate for governance structure, financing mechanism, service provision with a defined target population, and monitoring of quality care and performance. Third is formulate legislation to ensure protection of rights and entitlements of both older people and carers. Establish an overarching national and relevant regional plan, strategy, or framework that sets the directions and outcomes to achieve an organized and sustainable long-term care system operationalized at subnational level with a specified target population. Also, map key stakeholders in the development of policy and strategy for long-term care. One needs to formulate an explicit long-term care policy document developed as a standalone national document, usually including a multi-stage stakeholder process led or supported by the focal government entity dedicated for long-term care. Steer roles of national, regional, and municipal governments in the assurance, financing, regulation, and provision of long-term care services, including the role of public and private providers and non-governmental organizations. Next slide, please. One needs to establish a detailed action agenda with essential implementation strategies, create and support a regular decision-making body for integrating all levels of the long-term care sector, including collaboration of health and social workforce organizations, aiming at fostering dialogue and formulating processes, norms, standards, and regulations. Defining strategies and actions to facilitate leadership, foster collaboration between health and social systems, and enable alliances to promote more integrated models of long-term care. One needs to define how public funds will be allocated and distributed for the implementation of the national or subnational plan in a sustained manner. One needs to allocate and coordinate budgets across multiple levels of governance to implement an integrated long-term care system. Also promoting intersectoral collaboration, health and other government sectors, as well as representatives from private, voluntary, and non-profit groups to build on common goals and to allocate resources. Establishing mechanisms to review and share progress towards the national long-term care policy goals as defined in the plan or framework is an important component of the governance. Next slide, please. We need to establish and constantly refine the measures to track and monitor the long-term care national plan to ascertain whether it is implemented as intended and strategies are met. We need to configure audit activities to measure performance and transparency of responsible bodies. Monitoring performance of long-term care services in terms of their effectiveness, efficiency, economy, compliance with laws and regulations, contract requirements, grant requirements, and organizational policies and procedures. We need to also set out labor standards, procedures, and regulations for carers and care workers, such as working conditions, wages, working time arrangements, compensation mechanisms, and strategies to overcome informality. Promote the recognition of the long-term care workforce and the observance of workplace health and safety standards is of utmost importance. We need to provide an ongoing training program for carers, whether unpaid or paid, and formulate legislation for training and certification requirements to accredit people's caregiving expertise. Partnering with national, subnational, and local stakeholders and groups to identify and strengthen mechanisms to engage and empower communities in the process of governance. Formulating and regulating quality standards for long-term care services, whether provided by public, private, or non-profit organizations, by setting minimum quality standards for providers through licensing and certification, and carrying out periodic inspections to ensure their compliance and monitor their performance on quality. So these were the major components of governance. Next slide, please. Now we go to the second element, that is sustainable financing. The key aspects that should be considered for sustainable financing for long-term care are: establish a public long-term care financing system with a defined set of eligibility criteria that is used to determine access to and entitlement for a publicly funded range of services that should be available for people, as well as the responsibilities for long-term care. Recognizing that this does not need to be a standalone financing system, but a predictable financing system for long-term care that is well integrated with other health and social systems. Ensuring that public revenues are allocated and pooled for redistributive purposes to support equitable access to long-term care, and also allocate a sustainable budget to fund long-term care and related aspects, for example, long-term care information systems. In addition, we need to establish financing mechanism to ensure equitable use and universal coverage of long-term care and to support integrated care for older people, for example, outcomes-based financing, pay for performance, and bundled payments. Ensuring that public financial management systems are based on key local population needs and are able to allocate, distribute, execute, and account for funds. Implement mechanisms to ensure that those who are not able to contribute to the social insurance system, such as those not formally employed, are still covered if needed. Set up accurate measurement tools for current expenditure on long-term care as a proportion of other expenditures, for example, total health expenditure or GDP, as part of a national health accounts methodology. Ensuring that financing is based on accurate data related to costs. Set up measures and subsidies for reducing costs experienced by informal carers, for example, cash allowance, paid leave, respite service, or informal care leave. Next slide, please. Next element of this is information monitoring and evaluation systems. And the key aspects that should be considered for long-term care information monitoring and evaluation systems are identifying current and forecasting life expectancy, for example, median age, life expectancy, population growth, for example, fertility rate, migration trends, and old age dependency ratio, that is working age population related to older people. Survey populations, underlying chronic health conditions, and risk factors for the decline and loss of intrinsic capacity and functional ability to establish and anticipate needs. Monitoring and evaluating the levels of care and support needs among older people and carers is also an important key aspect. Integrating and link long-term care information systems with health information systems to ensure person-centered approaches. Also, track and monitor long-term care performance based on a broad and updated range of data sources, including facility-based information systems, public health surveillance systems, and population-based surveys. Surveying socioeconomic status of older people, that is family size, place of residence, household income status, poverty rates are also important components. Survey disability trends, for example, disability adjusted life year, long leading cause of disability need to be studied. Set up measures of well-being like life satisfaction, health related quality of life, and health status of older people and carers. Next slide, please. Now, creating integrated minimum data sets, that is clinical outcomes, integrated service targets, composite quality measures, which are used routinely to support the sharing of and improve the quality of information between all stakeholders is an important aspect. Determining intersectoral indicators of care distribution, quality, and equity, for example, provision of home modifications, transportation, and food and nutrition security. Identifying the number and geographical distribution of community social centers and number of people using these services. Auditing the number of long-term care facilities, their geographical distribution, complexity levels, number of beds, and number of care workers per number of beds. Mapping the number of health practitioners delivering long-term care services, for example, generalist medical practitioners, nurses, social workers, psychologists, geriatricians, physiotherapists, occupational therapists, gerontologists, community nurses, and carers. Mapping the number of practitioners working at the interface or transitions of care, for example, medical liaison, social protection worker care managers, nurse discharge managers, and also auditing the number and characteristics of older people receiving long-term care and their carers. And also, one needs to formulate measures for quality assessment, such as rates of available hospital admission, service integration, clinical outcomes, user satisfaction, and waiting times. Next slide, please. Mapping and generating reports of the characteristics of the services provided in terms of type, private versus public, size, quantity, geographical and quality distribution, including home-based services like outreach programs, daycare services, support services in primary care facilities, community-based centers, that is daycare centers and services, respite care, support services in primary care facilities, and also long-term care facilities like nursing homes, assisted living facilities, residential care homes, and hospices. So this comprehensive analysis gives you the continuum of facilities. Generating detailed data on financing, for example, out-of-pocket expenditures for long-term care, coverage based on eligibility, number of people who are entitled to long-term care, who have received a needs assessment in the past year, proportion of each type of long-term care services provided and by which sector, funding from healthcare systems versus dedicated funding for long-term care, proportion of care provided by informal carers and its costs. So this are the components or the key aspects for information, monitoring, and evaluation systems. Let's go to another element. Next slide, please. As we mentioned, the element of workforce is an important element. The key aspect that should be considered for long-term care workforce are identifying and regularly updating the number of carers, that is family members, friends, volunteers, paid and unpaid, and their profiles and needs. Identifying and regularly updating the turnover rates of long-term care workforce according to each setting, that is home, community-based centers, and long-term care facility. Also, formulating policies and legislation on registration, requirements, curriculum standards, care competencies, and certification for carers and care workers in each long-term care setting, including home care services, long-term care facilities. regulating annual pedagogic inspection, in-training requirements, and pedagogic supervision regularly assured by an accredited supervisory body for staff in each long-term care setting. Formulating evaluation and mechanisms for current workforce capacity, that is specialization, training and retraining courses, and monitoring, for example, skills and satisfaction. Formulating and setting up mechanisms to ensure gender equity in care provision, for example, flexible working and learning opportunities for women who are or were carers, benefits and entitlements for returning to work. Formulating and setting up mechanisms to ensure staff retention and minimum staff ratio, for example, flexible working arrangements, minimum established salaries, target based awards, career development and promotion. Setting up strategies to measure the availability of workforce capacity building initiatives that are responsive to population needs. Formulating policies to support carers and promote their mental and physical well-being. For example, respite, daycare centers, home support, and food support and dementia. Next slide, please. Next important aspect is service delivery. The key aspects that should be considered for long-term care service delivery are setting up a strategy formulation process for quality assurance, defining a strategy for quality-related measures, and establishing a body with responsibility for quality control, set up assessments of perceived quality by users and providers in the services provided, planning the service provision based on accurate data on the number of home care provisions, community-based centers, and long-term care facilities. Setting up standardized person-centered assessment protocols, including degrees or levels of dependency categories, health criteria assessment to qualify for services, preferences, and older adult and carer needs. Formulating control mechanisms to ensure that providers, that is public, private, non-profit, or commercial, are respecting, that is, they should respect the minimum standards conducted by independent institutions, inspections, and public reporting. Defining evidence-based care pathways based on clinical guidelines, systematic reviews, and best practice recommendations from recognized organizations. Next slide, please. Defining clear quality standards for provision of long-term care across different settings based on fundamental rights, evaluation of needs-oriented care, and preferences, for example, accreditation mechanism, hospitalization rates, unintended injuries or harm, such as pressure ulcers or falls, levels of satisfaction, and medication-related incidents such as over-medication and medication errors. Defining clear processes and procedures to create integrated and person-centered care pathways, that is transition policies, case prioritization, case and care management. Providing timely, integrated, person-centered services inclusive of all aspects of the continuum of care, that is preventive, promotive, rehabilitative, curative, palliative, assistive, and social and carer support. Set up strategies for coordination and communication systems between services providers, health care workers, care receivers, and carers, including sharing information between clinicians about patient care. Next slide, please. The next element of this continuum of long-term care is innovation and research. The key aspect that should be considered for long-term care innovation and research are encouraging high-quality research and setup in collaboration with national and regional research agencies, specific research grant schemes dedicated to long-term care, formulating an innovation and research plan and revise it periodically in line with current national and subnational policies, creating an expert advisory commission for the long-term care research agenda that includes researchers and key stakeholders as well as older people and carers. Identifying partner organizations, fund or co-fund specific projects that are perceived as high priority research. Establishing annual funding investment in long-term care innovation and research. Encouraging subnational research initiatives that provide regional policymakers with information on cost-effective policies, developing databases to support analysis of subnational variation, fostering a continued dialogue between researchers and end users, that is, older people, carers, staff in long term care facilities, home care providers, to identify and address information and quality gaps at a micro level, that is, needs of older people and carers, at meso level, that is, care service delivery, and macro level, that is, policies, strategy, and legislation. Promoting improvement in the quality of education and capacity building of human resources by encouraging postgraduate student programs and young researchers. Next slide, please. Generating indicators to measure the level of implementation of innovation and research on long-term care practice, facilitate and encourage technological and policy innovation, leveraging national and regional agencies and hubs to build on long-term care, promoting the adoption and uptake of innovation by engaging in partnerships, that is, universities, research institutes, networks, and business associates, creating mechanisms to accelerate innovation in the sector by supporting the implementation of well-validated strategies and programs in long-term care practice, showcasing innovation experiences and success stories in adopting long-term care solutions and innovative ways of delivering interventions. Value the expertise of long-term care staff and carers by implementing staff and carer-driven innovation programs, fostering the development of digital information technologies to facilitate communication and information exchange among sectors and stakeholders. Next slide, please. Here, I will like to share with you one example of Singapore. Kampong Admiralty in Singapore's first public housing innovation that integrates housing for seniors with a wide range of social, healthcare, communal, commercial, and retail facilities under one roof. Completed in May 2017, the 11-story vertical kampung, that is a Malaya word meaning village, features studio apartments fitted with older people-friendly features, a medical center, an active aging hub, a childcare center, dining and shopping facilities, a community plaza, community park, and community garden. With this wide range of amenities in close proximity to where seniors live, Kampung Admiralty is designated to enable seniors to age in place by encouraging them to lead active and healthy lifestyles and by promoting intergenerational bonding. For example, the Active Aging Hub offers active aging programs such as life skills courses for seniors and preventive health programs such as health checks and fall risk screenings to help keep seniors in the community healthy and safe. A community nurse is on site to check the seniors' vital signs and advise seniors, referring them to specialized care if necessary. The Active Aging Hub is located beside a childcare center, which makes it easy to hold activities that promote bonding across generations. Next slide, please. In line with the move to transform Singapore's healthcare delivery system from one that is built around the hospital to one that is centered in the community, the medical center at Kampung Admiralty offers selected specialist outpatient services, day surgery, endoscopies, rehabilitation, and diagnostic services. An in-house diabetes center provides care for complex diabetes patients. On the preventive health front, the medical center provides a range of community health education and chronic disease management programs. Hence, the medical center offers increased convenience for seniors to access specialist care without having to go to a hospital. Next slide, please. And this is the all-in-one village. How the Continuum is built, and it's a village, and it's for integrated care for healthy aging. You have green features, you have community farms, you have the people who can interact with each other yet have their life centered in a place where they can get all preventive, promotive, curative, palliative, and social services at one place. So that's why research into innovation is very important for long-term care, where we devise policies and programs which are relevant to our country. This is only one example. There are other examples, say in Germany, there are a number of other examples of similar nature. One needs to experiment and innovate. Next slide, please. Another important aspect of this continuum is learning from the COVID-19 pandemic. Globally, the COVID-19 pandemic has exposed the fragmentation of long-term care services within existing systems of health and social care, along with inherent weaknesses in the current overarching governance structure for long-term care, including lack of legislation, poorly qualified and low-paid staff, and inadequate national strategies and frameworks for long-term care. Around the world, but particularly in low and middle income countries like India, long-term care facilities represent a diverse sector that operates without proper regulation, which contributes to the poor quality of care provided to residents. And let's face this reality and tackle as experts in this area. Next slide, please. Sectoral informality with poor, unreliable information about long-term care facilities and the lack of national registry database has delayed coordinated governmental responses to control the virus transmission and avoid deaths, particularly in low and middle income countries. The pandemic has highlighted the need for strengthening relationships between different levels of government involved in social care and healthcare and developing concrete vertical and intersectoral coordination mechanisms. Next slide, please. The global crisis has reinforced the importance of identifying mechanisms to ensure quality services in both the regulated and the unregulated long-term care sectors, and to strengthen accreditation to ensure health sector oversight of long-term care facilities in order to prepare for future pandemics and guarantee human rights. That should be the biggest learning from this pandemic. Long-term care needs to be strengthened sooner than later. If we really show the people that we care and we care more and we are prepared to manage any pandemic that occurs in future. Next slide, please. Attention is the rarest and purest form of generosity. I am thankful for your generosity as you have given attention during my presentation. Thank you so much once again.
Thank you, Dr. Rajiv Jain, for an elaborate and in-depth insight into the long-term care needs of the future. Now, the topic is open for discussion. Anybody who wants to question can unmute the mic and directly ask the question, or else I will set the ball rolling by asking Air Marshal Pavan Kapoor to come for a comment or a question to the speaker.
Okay. Yeah, good evening, everyone, and thank you, Dr. Rajiv, sir, for a wonderful presentation and such a comprehensive presentation on integrated care for the, elderly. I think it was very well presented, and you have given a right from the resource requirements and how we should move forward. And you've given a very nice example of Singapore also. Sir, I have certain this thing. We have instituted a national program for healthcare of the elderly. If I remember correctly, way back in 2008 or 10, somewhere that time, we have had a very good concept at the regional level. We must have a geriatric ward with daily geriatric OPDs, a 30-bedded ward. At district hospitals, we must have a 10-bedded geriatric ward and another geriatric clinic there at community health center, and all those levels, at least a geriatric clinic there, and domiciliary help to be provided by trained manpower to the elderly. We have a very good, well conceptualized program with all details being laid down. I have not seen it being implemented on ground. As per whatever limited experience I have got, I don't know how far we have progressed ahead in our commitment to the care of the elderly. So can you throw some light on this aspect of implementation of our own national program?
Well, exactly. That was the need. In fact, when I was thinking of the one aspect which needs to be discussed in our webinar of Academy of Hospital Administration, this was precisely the reason. Thank you, Dr. Babakar, for raising this important issue. We may build a program on paper, but when it comes to implementation, we falter on the way. The progress has been slow and progress has been not comprehensive. What is needed on the ground by the people is a continuum of long-term care. It is not one-off care. It is not one-day care. It is not. It is not actually a care which is delivered in a manner that you start in one day and you finish another day. It goes on till the life goes on. That kind of care is what is required. That linkage between social services and health services is what is of crucial essence, and that is what is lacking in our system. And that is why I thought of bringing out a roadmap, because the national program for elderly needs to be redesigned, where we link the two. If you look at the program for the children, for the newborns, there is a linkage. If you see the services provided on the ground, the Anganwadis and the child health services, immunization are linked together. Nutrition is linked with that. It does not happen for the long-term needs of the people who are aging. And when we talk of aging, I do not assign a figure of, say, age, chronological age, because it is not comparable. The person who is aging, maybe 40 years, maybe 60 years or 80 years. Depends. Each individual ages separately, is its own trajectory. So the needs are to be tailored according to the individual needs and should be available on the ground. What is required is a reform at the state level, where the program is designed and delivered. Health being a state subject in India, each state needs to devise a program, and central government should be only facilitating the process of the program designed by the state government. That is what is of crucial essence. And that's why in the model that I showed you, the linkages come very crucial. The state to state government coordination, the platform where state government expertise is used for each other's benefit, not at counter purposes. The central government, yes, it has a role in, as I given in the elements, the key aspects, the innovation, research, financing mechanism that could be handled through a coordination mechanism at the center. So that is what the reason why I presented this model today. National program is going in because in one plan it gets some funds, other plan does not get as many funds. The program goes in many directions at the moment. It's not seeing the light of day, as you rightly mentioned. That's why the private sector is dominating, and you find people are investing money, which is not of good quality.
Yeah, because what you brought out was very clear, that it should be accessible and affordable. The other two dimensions of quality which should be inbuilt into such integrated care. And for doing that, somewhere down the line, the state governments will have to play the role that they are expected to play. Because why I am worried. Of course, we are all in that age group. We are gradually progressing to the care of the elderly age group, and therefore you are worried about your own care as well. But leaving that aside, my worry is that what we conceptualize, and if we have not been able to make the basic requirements of elderly care, then this beautiful system that you have presented here, which is the need of the hour actually, how much time will India take to implement such a system when they have not been able to implement the basic system which they laid down for themselves? A very simple model. Regional, we must have this much, in district level this much, community health this much, in private health center this much, and sub-center level this much. This is what we require to do, and train the manpower. We have not been able to give this much of this correlation could not be carried out. How do we do what system other countries are following? That is the cause of worry for me. The second thing is this: can we have a suggestion to the government that if you cannot do it, you have conceptualized a beautiful program, you cannot implement it, take some small states. I'm sure like Dr. Yashpal is there in Jammu and Kashmir. If you take that state and implement in one state a part that program fully and showcase it as a model program, but that has to be done, with a lot of political will also. So I really do not know that are we serious about our elderly? This is the question which I'd like to ask each one of us. Are we serious about elderly? Because once we are there, we think we are not going to become elderly. Once we become elderly, we start thinking of chronic care. That should not happen. So I don't know. I think we have to think out of the box to get something implemented.
Very right, Dr. Pavan.
Yeah.
Yeah. You're right. But one state which has taken the lead, I would say, is Kerala. The models of palliative care, they devised, they implement it on their own. And they fund it through their own, community-based funding mechanisms as well. And it was working. It was working better. And it has to work in a society where the social systems are very strong. And Kerala fortunately had a very strong social system with well designed linkages with the healthcare system. And that's why palliative care could get established in specific districts in Kerala. But that needs to be diffused to other states in our country. That is what makes me think that we can implement easily. It's not something we could go abroad to have modeled. We have good models. Only thing is we need to now push it further across. If it is Kerala, then it could move to Karnataka or Tamil Nadu at least, or Maharashtra, which are forward-looking states, good social networks and healthcare infrastructure and education as well.
Thank you, sir. Thank you very much.
Well, Dr. Yashpal Sharma has a challenge. If you could think of, I think that would be a biggest achievement of Jammu Kashmir government.
Yeah, that's right, sir. In fact, I would like to add here that National Program for Elderly Care was, in fact, very well conceptualized and very well planned program. And it initially its implementation was also there. I can say district hospitals, CSCs, and PSC level, the infrastructure which was required to be created was done. But unfortunately, what the way we have been working, that's not correct, because once the program is implemented and handed over the states should take over, and then this should keep on working on it. Now that focus on this program is not much. So you must have seen in last 3-4 years, the program is almost forgotten. Nobody is caring about it. The wards which were established, I don't know, are being used or not. I'll give you one example of a small place, Leh. Leh, I have been visiting as a mission director, national mission, very regularly. So they were really implementing it to the full. They had very good wards. The elderly were admitted there. They were giving free treatment, free food, everything, because everything was inbuilt in the program. And there are some places where once some program comes, they start doing it and keep on doing it without waiting for the funds or other things to come from the center. But problem in most of the states is that every program has to be pushed by the center itself. Once they forget or have some less focus on it, the states always miss the bus. They miss the program. Like now, the focus is on it. And I think this is one of the very important topic as such. Very rightly chosen, and sir, you spoke very well. I congratulate you for that, and you have given a roadmap also. But Sir Kapoor sir has rightly pointed out that there is a program, it's a national program, and this program should be implemented in letter and spirit. In fact, you have given a challenge to us also. Maybe I'll also discuss about it, because I know as far as JNK is concerned, we have in most of the district hospitals the ward for elderly. Most of the CSCs we have, and PSCs also, some of the PSCs were selected where these were created. Once the infrastructure is created and the manpower is trained, it is not that difficult to implement. So it can be taken as a challenge and done, sir. Not a problem, I think. Thank you.
Okay. Over to Dr. Ashutosh. To you. Ashutosh, go ahead. Ashutosh Sharma.
Yeah, yeah. Thank you, sir. Thank you, sir. No, my only point was that, yeah. Am I audible?
Yes, yes, you are.
Yes. So
Yes,
my
yes, you are.
point was that this kind of a program would obviously run by a government only. It is not financially viable. The amount of utilization of this category of personnel, like we all, would always be very high. So it will not be a model that the private sector, what I can imagine, would want to invest in. Only as far as the government can run. And government would be whether it is city centric or it goes down to the last person. I think these are the limitations. Even if you see from the government's perspective, if I have to put myself in that place and see, if you invest in a pediatric age group, with the example which was given, the juice is much worse than the squeeze. Whereas if it is for this kind of a category, it's neither news nor value seeming to be. We all would want to agree it's very valuable. So unless a model can come out where even the private sector can come into it and then spread it, because insurance won't take this group. In fact, I was trying to look for insurance at the turn of 60, very difficult to find somebody. So these kind of issues would be there, but let's all work towards it, starting with the government, and maybe at some stage others come in. That's just my point, sir.
Okay, thank you.
Very rightly, Dr. Ashutosh, you have raised the issue. In fact, the United Nations that they have now had a consensus resolution passed 2130. 2021 to 2030 is the decade of healthy aging. And investment from the UN agencies is forthcoming to help low and middle income countries, like we are in the low income countries. India is eligible to get preferential funding for devising and implementing healthy aging programs for our country. So this is the right time. 2021, 2030 is the right time for the state governments and also the central government to move fast in this direction. The funding through taxation-based mechanisms shall be forthcoming in the post-pandemic period. And that is a golden opportunity. People who never cared for their society or community living, good quality of long-term care needs, are willing to pay a little bit more for general taxes. So I think these two factors would make it viable. You are rightly saying that it has to be publicly funded. There is no other way, because this is so much requires a public commitment. And the only way the public could say that we are committed to long-term care is through paying the taxes.
Thank you. Over to Dr. Shalu Verma. Shalu, please go ahead. Shalu, you had asked a question.
Oh, so, Jain, sir.
Go ahead.
Admir Shalu here, sir. Sir, I know this topic was very useful and very informative. Thank you, Dr. Rajiv, sir. Sir, and Dr. Ashutosh, I'm really impressed by the presentation sir has given. Sir, one of my point is that, sir, when we come to India, foreign culture it's okay, sir. Elderly person are living alone. There is no emotionally attachment being is there. But in India, our cultural value should be strong enough that we can look after our parents, as the High Court and Supreme Court says that whosoever is not doing parents care and all, they are disqualified from their benefits and their money, their properties and all. So we should build up that much of this one, we can say, our cultural values to our kids when they are growing up in schools, colleges, and upper educations. So that is my point. So we should take care of this point also, so that after all, we are all are Indian. So we should be emotionally strong with the kids, that we don't require such hospitals in India further. That is my point, sir.
Thank you, Shalu.
I would say the point you've raised needs to be considered in terms of the needs of the people who require long-term care.
So,
And if you had seen the workforce aspect, I meant distinctly separate the two kinds of workforce. One are the carers and the carer workforce. The paid workers who care supplement the family caregivers, the family or the neighbors. So you need to work in a very dynamic fashion. Sometimes the people who require very chronic assistance, even for daily living, one cannot do, the family itself will not be sufficient. Otherwise, they suffer double jeopardy. How will they earn? They have to, devote time for earning for the family as well. So there is a need for having both the kind of workforce, the caregiver and people who work to give care. And that is why increasingly now, the fortunately in India, private sector has come forward. There are standards also. The health sector council has standards, and there are a number of companies, startups, which have garnered this beautiful opportunity of providing long-term care. Of course, it is for payment, but that gives a beautiful way of understanding that it can be sustained, and the care that is given prolongs life. But it is not a question of prolonging life, it's a question of giving quality life to the individuals who are aging and who will continue to be aging for years to come, say 10 years or 15 years. So the attempt here is to provide a sustainable way of providing good quality long-term care
so
and ensuring healthy aging. So that of course one cannot neglect the culture that we have in India. In fact, this is the best way to ensure that we maintain our culture in spite of all the forces of urbanization and other changes that have come up with development in our country.
Dr. Rajesh
thank
Bala,
you.
would you like to make a comment here? Anybody who wants to make a comment? Over to Dr. Yashpal. You can make a comment here and conclude it.
Yeah, I think I would make an announcement rather than comments. I think
Yes.
first we thank Dr. Ajib for excellent presentation, and thank all the senior colleagues who have joined us here. Uh, and all senior colleagues, Dr. Bhalla is also there, I can see him now. All senior colleagues for joining today's webinar. And it has been, excellent talk, and we really enjoyed it, sir. We wish that and hope that you will be frequently joining us for such webinars. And next webinar we have planned as a success story of Meditech growth story in India, Andhra Pradesh MedTech zone. So Dr. Jatendra Sharma, who is Managing Director and Founder CEO of Andhra Pradesh Meditech zone, will be with us on 26th Feb from 3:50 to 5 p.m. This time, time slot we have kept a bit because otherwise we are there from 4 to 5. So this time it is from 3:50. So he has also published recently a book by the name Made in Lockdown. Very interesting book, and you will be surprised to know that in 342 days they have been producing 100 ventilators, 500 oxygen concentrators, 1 lakh and 95 masks, and 10 lakh RT-PCR per day. That's a huge number. So how he has been able to do all that? He will be interacting with us. He's one of us as a HA member, and we are really proud of him. So this is what I wanted to tell you all, and I'll request all of you to be there to encourage him, to listen to him, so that we can move. It's a open public session. You can interact also, and hope few people have visited that place. I have been lucky to be there and see how the progress is being made. So this is all from our side. In fact, I would request all of you to be more interactive on the social media. HA website has also been renovated. It is, a new website has come, and even the membership drive is being done through straight through the EHA website. Please visit website also. Then all social media pages we are active. This today's session will also be there on our YouTube. Please visit all the sites and like, so that we can have more of the members also. So thank you very much, Dr. Ashish. You have been always been wonderful coordinator. You have been coordinating very well. Thank you all. Dr. Ashutosh has also joined. Dr. Kapoor sir, and thank you once again, Dr. Rajiv. Over to Dr. Ashish for final.
Thank you, President sir. So I think with this very, upcoming type of health system, we have to look into, with 2/3 of people, elderly people who need at some point of time some assistance in their routine living. And the take-home message Dr. Rajiv Jain has given to us today is that whatever care process we make, long-term care process, it should be based on three major pillars. It should be equitable, affordable, accessible. It should uphold the honor, rights, and dignity of a person, and it should be person-centered, not the service structure centered. That is what I think Dr. Rajiv was trying to push through. Thank you, Dr. Rajiv. Any last word you want to say to the audience? You can say now, sir. You please unmute yourself. Yeah.
I'm grateful to the Academy, especially Dr. Yashpal Sharma and the entire team that is having at Academy of Hospital Administration. This process, I'm finding it's very useful, and pandemic has been a blessing in disguise. The academic activities have taken off very well in the Academy of Hospital Administration, and the YouTube channel is getting good number of views. The Twitter handle is also working fine. I think the website is very well designed, and we believe that post-pandemic would be definitely a better world, because we will get used to the hybrid way of working, where physically we will go move sometime, but mostly we will go online, be comfortable with these kind of interactions and these kind of academic activities. Thank you.
Thank you, Rajiv.